Hi everyone. Hi Shusan Ponsan and all sector members. I'm Koichi Kashiwa from the Japanese Society of Extracorporeal Technology in Medicine and I work for the University of Tokyo Hospital. I'm very grateful for such a wonderful opportunity. Today I would like to speak to you about the management of BB ECMO for COVID-19 patients in Japan from the viewpoint of clinical engineer. First, I'd like to give you some background about ECMO in Japan. Secondly, I'm going to talk about the efforts of the Japanese Society of Extracorporeal Technology in Medicine. Thirdly, I'm going to move on to the introduction of the BB ECMO management for COVID-19 specifically. I will also show you the BB ECMO circuit configuration and infection protection in the University of Tokyo Hospital, which I work for. First, I'm going to talk about some background ECMO in Japan. In 2017, there were 1,147 ECMO machines in 466 hospitals. Nowadays, I've heard the amount of ECMO machines are over 1,400 in Japan. So ECMO is performed everywhere. This slide shows the system for the certified clinical perfusionist in Japan, which is called CCP. It was established in 1987, and the certification board consists of JASA, JTS, JSCVS, and JaSECT. CCP has been nationally recognized as an indicator of perfusion knowledge and technology. You can see the details on this website. CCP plays a key role in ECMO management. This slide shows the number of the CCP in Japan in March 2020. There are CCPs all over Japan. I'm going to introduce how our society advocated useful information for JaSECT members. Most facilities in Japan have lack of BB ECMO experiences, and the majority ECMO cases were BA ECMO. Also, we needed evidence-based information on COVID-19 initially, but unfortunately, it was a shortage of useful data. That's why we thought we must give information to JaSECT members about how to manage BB ECMO and infection control. Therefore, we posted on the website about past papers published in our journal and information on methods for COVID-19 ECMO management from April 10, 2020, over 4 times in total. Also, we published in the journal featuring BB ECMO. This is the journal of the BB ECMO special edition. There are 2 review articles and case reports from 6 hospitals in the journal. Now, I'd like to talk about the management of BB ECMO for COVID-19 from the contents of these reports. First, I'd like to talk about cannulation configurations and cannula sizes. As a standard recommendation, cannulation should be performed under fluoroscopy. However, many facilities brought X-ray equipment and ultrasonic diagnostic equipment into patient bedroom for cannulation in actual practice. Cannulation areas were commonly chosen from femoral to jugular or jugular to femoral. The size of the drainage cannula was often selected, 25 French. Next, I'm going to explain the ECMO management protocol. Many facilities seem to manage as follows. In ECMO perfusion conditions, target flow rate was 4 to 6 liters per minute. Sweep gas FiO2 was 1.0. Gas flow was 3 to 4 liters per minute. Post-membrane lung blood gases PaO2 and PaCO2 were 350 to 500 mmHg and 35 to 45 mmHg respectively. Temperature setting of heat exchanger was 37.5 to 38.0 degree to prevent sievering. In other coagulation, many facilities seem to manage by ACT and APTT. The ventilator management was following the lung protect ventilation strategy in all facilities. SpO2 was targeted 80 to 90% in the position and respiratory rehabilitation. It was varied depending on the facilities such as actively changing the position, performing from position therapy, and preventing pressure ulcers. This map illustrates the layout drawing of patient bedrooms of our hospital for critically ill COVID-19 patients. Basically, we have used the 10 private rooms, including 4 depressurized rooms. The beds, except in private rooms, have not been used. These pictures show the corridor of the emergency ward and the patient bedroom seen from the corridor. Medical workers can check an operation panel of an ECMO machine from the yellow zone from the glass window. We reduce the amount of time staff spend in the red zone by using this window. Nurses mainly have checked for blood clots of ECMO circuits. When a clinical engineer entered the red zone, many facilities reported that the behavior was monitored by another clinical engineer in the green zone or yellow zone. Many facilities reported that the number of blood draws was reduced by using a continuous blood gas monitor. There are differences between facilities in terms of PPE wearing standards in the red zone. The facilities where medical workers always wear a gown, face shield, N95 mask, cap, and gloves. The facilities where medical workers wear only a gown, surgical mask, and gloves if they do not come in direct contact with the patient. This slide shows the PPE wearing standards of the University of Tokyo Hospital. When we contact the patient and conduct treatment generating aerosols, we must wear gloves, long-sleeved gown, face shield, cap, and N95 mask and surgical mask. When we contact the patient, but we don't do any treatment generating aerosol, we don't have to need to wear an N95 mask. However, it does not deny wearing an N95 mask. Then, I'd like to talk about measures for plasma leakage of oxygenator. This slide illustrates several oxygenators which are used widely in Japan. Those materials are asymmetric membrane and the silicon-coated polypropylene membrane. This type of oxygenator is designed to prevent plasma leakage by means of its silicon coating. However, silicon coating does not completely cover the polypropylene membrane in this oxygenator. As shown in this photo, plasma leakage sometimes occurs while using this oxygenator. It may occur the plasma leakage in the oxygenator with the asymmetric membrane as shown in the right photo. Many facilities seem to take measures for plasma leakage because it was introduced in the webinar held last year that there was a concern that the oils in plasma might spread as an aerosol from the oxygenator gas outlet port. I'm going to introduce papers and use methods for ECMO management in our journal. This paper shows that SARS-CoV-2 leakage might occur from blood to the gas outlet port of the oxygenator through silicon-coated polypropylene membranes, regardless no visible plasma leakage during ECMO support of critically ill COVID-19 patients. These results suggest that proper handling of the oxygenator in the ECMO system is a crucial consideration for infection control. This slide shows three major introductions. First, it seemed many facilities covered the oxygenator with vinyl bag. Next, there was also a facility putting the super absorbent polymer in the bag and hardened it when plasma leakage occurred. Third, there was also a configuration device as shown in this photo, which was the method of covering the oxygenator gas outlet port with an echo probe cover and connecting the other side to a plastic container for personal diuresis tube. A ventilation exhalation filter was installed on the other side of the container to exhaust air. I introduced how to prevent condensation in our journal on this slide. There are three types of ways. First, it was the method of warming an oxygenator with warm air from patient warming system. Second, using the automatic gas flash device. Third, staff put on the N95 mask and face shield and perform the gas flush. Then I'd like to talk about the weaning test from ECMO introduced in our journal. Many facilities mention the two criteria for starting the weaning test. First was the improved lung permeability in chest X-ray images. Second was that the SpO2 was 90% or more. In the blood flow rate, there were facilities that decreased blood flow rate or did not change during the weaning test. And it seemed that the sweep gas flow was decreased 0.5 to 1 liter per minute each after gradually decreasing FDO to 1.0 to 0.21. Many facilities are referred to the protocol in this paper in Japan recently. We must assess separately the patient's dependence on ECMO by conducting two sequential steps in any cases. In the first step, we reduced FDO2 progressively, and next step, the sweep gas flow is reduced gradually. But the blood flow rate remains unchanged throughout the procedure. This paper shows that the activity retention period was 3, 4, 24, 48, and 72 hours on aerosol, copper, cardboard, stainless steel, and plastic surface, respectively. Therefore, it goes without saying that we should clean up the machine after using. All facilities reported that it was cleaned up with 60% or more alcohol or chlorine-based disinfectant cleaner. Some facilities reported adding UV sterilization with UC irradiator. Then I'd like to talk about the coagulopathy of COVID-19 patients. SARS-CoV-2 infection have been shown to be associated with a high rate of thromboembolic events due to coagulative mechanisms that have not been fully understood yet. However, it is believed that the coagulation reaction associated with excessive inflammation is strongly involved. For example, cytokine storm due to excessive cytokine protection nets increase of factor 8 and von Willebrand factor, the emergence of loops anticoagulants that accelerate blood coagulation and platelet aggregation, and activation of complement that damage vascular endothelial cells. COVID-19 patients often have high fibrinogen levels. It has been known higher levels of fibrinogen render resistant to heparin in addition to the known reduced levels of antithrombin in COVID-19 patients. Strict and stage-adapted anticoagulation management is crucial for therapeutic success. That's why anticoagulation management in ECMO-treated COVID-19 patients must be adjusted based on the patient condition and various data. For example, ACT, APTT, the number of platelets, fibrinogen level, TAT, FDP, D-dimer, antithrombin activity, a consequence of viscoelasticity test, and so on. I'm going to introduce the ECMO system in our hospital. This slide shows the ECMO circuit of our hospital. We have monitored centrifugal pump pressure and transmembrane pressure gradient to assess oxygenator function. If the thrombus sticks to the inlet port of the centrifugal pump, we must exchange the ECMO circuit. This slide shows the changes in pressure and flow rate due to changes in the occlusion rate of the centrifugal pump inlet side circuit. This graph shows that significant changes in flow rate and centrifugal pump pressure occur when the occlusion rate exceeds at 70%. That's why we must prepare for circuit exchange quickly if we detect these changes. This graph shows that the same can be said when the transmembrane pressure gradient rises. This table is a common one, but we should recognize that more than at 70% of the circuit is occluded when the changes in pressure or flow rate appear. Finally, I would like to talk about the importance of education for other medical workers. Originally, the lack of PPE restricted clinical engineers from entering the red zone, and the reliance on nurses for ECMO management increased. Many facilities mention the necessity of collaboration with other medical workers. At the University of Tokyo Hospital, the simulation training course using CPB simulator have been provided for nurses who work in ICU. This tough situation cannot be overcome without the cooperation of multiple occupations. It is important to educate ECMO for other medical workers to demonstrate team strengths. These are the conclusions. JaSECT provided information on COVID-19 to its members using website and journal. All ECMO case reports for COVID-19 patients describe the importance of infection protection, coagulation control, and multidisciplinary collaboration. We will keep updating ECMO information for severely ill COVID-19 patients as long as this situation continues, because it is our duty as an academic organization for extracorporeal circulation to disseminate accurate knowledge and response in a timely manner. Thank you for listening. I look forward to seeing you again.